Good day, everyone. Before starting this lecture on uterotonic drugs, I request all of you to subscribe my YouTube channel, Painfree Partha, and support. So today's topic is about uterotonic drugs. So all my slides are available in painfreepartha.com. And welcome again from our institute, Mahatma Gandhi Medical College and Research Institute, Pondicherry. Why do we need uterotonics? To induce labor, to prevent postpartum hemorrhage, and to treat PPH. These are the three indications. Why do we need oxytocin? Induce labor, prevent PPH, that is prophylaxis, and then treatment of postpartum hemorrhage. There is a saying that it did not take care very long to die. That is the best problem, most important problem in cesarean section or normal delivery. Within seconds, within 30-40 seconds, she would have bled around 1000 ml. This is the problem. This is not very common with other surgeries, routine surgeries I am talking about. Every year, so many women die of obstetric hemorrhage. And these drugs are used routinely, and they have sometimes a narrow therapeutic safety of margin. So that is why we need to know these drugs. So many people die of hemorrhage. There are three classes basically. One is oxytocics, another is ergots, another is prostaglandins. These are the three classes of uterotonics. Now we will go to oxytocin. This oxytocin, pictures modified from the internet for closed economic purpose only. Oxytocin here, it acts on the oxytocic receptors basically to increase the myometrial calcium so that it contracts the oxytocin receptors. This prostaglandin also is acting through calcium, but that is a different mechanism. So this calcium is the main source of myometrial contraction to be induced by oxytocin from this side and prostaglandin from this side. So the concentration of myometrial receptors increases gestation advantages. That is what is the important thing. There is increasing sensitivity to oxytocin. Now you get 28 weeks, 30 weeks. After that only the oxytocin receptors will have a say. At 16 weeks, 12 weeks, if you give oxytocin, the receptors may not be sensitized to these things. So it may not work in such cases. So what is the pharmacodynamics? It causes contraction. That is very important, followed by a relaxation of the uterus. And can pharmacological doses increase the frequency and incomplete relaxation also? That is what is important in oxytocin. That is why people use it as an infusion. That is why we give IV followed by IM. That is why we give followed by IV followed by an infusion. So sometimes it can cause a contraction followed by an incomplete relaxation. So we need to target the drug continuously till we get what we need. Desensitization of that is also important in myometrium after prolonged exposure to oxytocin in labor. Now, for example, if the patient is on 3 days oxytocin, after that they have decided that to give for anesthesia for spinal for or GA for cesarean section. And here the oxytocin receptors may be desensitized because he may be getting 10 units going on for days together, and hence at the time of delivery the patient may be slightly desensitized. So we may need to try other type of drugs. There are innumerable regimens as innumerable anesthetists. Everyone gives their own way. 5 units intravenous bolus followed by 40 units diluted in 500 ml saline for 4 hours. This is one. Give IV5 and then 40 units in 500 ml in 4 hours. 15 units in 1 liter saline and infusion for 1 hour. And 20 units followed by IM. Even they have put, there is a recent article in Indian Journal of Anesthesia that give 3 units IV. That is enough. That is what is they have found out the hemorrhagic sequences. 5 units intravenous bolus followed by oxytocin. There are innumerable regimens. So what I follow is I give 5 units IV followed by 10 units, because one major problem is if you give 40 units and give it slowly, when the patient bleeds, sometimes we may need to have one more IV line for the infusion of IV fluids. And here, so in cost or low resource settings, yes, adjust it with 10 units in 5 ml. Start using slightly, we can increase the dose if we need IV fluids. There is something called inhaled oxytocin for prevention of hemorrhage, a modeling study to high burden settings, because we cannot have time to this thing. Give it to them and just. And also we can have pre-filled uniject syringes at the time of in many of the developing or underdeveloped countries or developing countries like Egypt, Turkey, and all. What they do is give it to the mother the pre-filled syringe. As soon as the delivery is there, inject themselves. So sometimes a nursing supervisor may be there. So this is what is pre-filled uniject syringes and inhaled oxytocins. The number of oxytocin, yes, this is what I have been telling. We expect oxytocin to rise during the course 73.2% from 1 to 3rd trimester. That is what is important. Around 25-26 weeks later on, the oxytocin receptors. If you have an hysterotomy, surgery at around 20 weeks, because there is an anomalous baby, they are removing it. Yes, we should think the receptors are not formed very well, and we need to use other non-oxytocic uterotonics. This is very important because oxytocin receptors continue to increase only after the advent of the 3rd trimester. Now, this is about myometrial contraction followed by an incomplete or infrequent relaxation. This is about its action on the uterus. Now we go extrauterine actions. Oxytocin creates a sense of pleasure, prompts us to repeat the act in hugging. The release of oxytocin tends to alter, which produces, see here, processing of emotional stimuli, oxytocin. Let down reflux, nipple to hypothalamus, breast milk expression, relationships and bonding with breast milk and baby mother bonding. All these things, oxytocins are involved. Oxytocin is a vasodilator. That is why many people don't give IV. So you will give some hypotension. Reflex tachycardia. We have used 10 units versus 2.2 units. But you think all these things matter in patients where there is a definite cardiovascular hemodynamic compromise, like severe aortic stenosis or mitral stenosis or a severe pulmonary hypertension. So this is what is matter. So in routine cases, if we give IV, it doesn't matter. What all we should think before giving straight IV is all these dangerous clinical systemic conditions. Are we encountering these systemic conditions? Yes, beware that there may be a hypotension with oxytocin use. See, psychiatric oxytocin deficiency is associated with depression, anxiety, sleep disturbance, isolation. There is a relationship to oxytocin, autism, schizophrenia. Uterine contractions are seen. This is what we have found out with oxytocin in relation to pharmacodynamics. Pharmacodynamics is uterine action, extrauterine actions, the down reflex, breast feeding, cognition, hugging, psychiatric, schizophrenia, autism, so many other actions have been now attributed to oxytocin. There are IV, IM uses, 5 units followed by 40 units, 5 units followed by 10 units infusion. All these things have been there. Uniject, pre-filled syringes, and inhaled oxytocins are available. Now we go metabolized and excreted. 15 minutes, probably the action is over. And if you give IM, it may be 45 minutes. What are the possible side effects? May not have encountered much, except one thing which I have encountered commonly is a headache. Excess contraction and possible rupture, very rare. Mild hypotension is common. Memory problems or confusion, very rare. Running nose, sore throat, coughing, rare. Seizures, severe hypertension is extremely rare. So what we find out normally is a mild headache and a hypotension. This is what commonly occurs. Excess contraction is relatively rare with oxytocics rather than with prostaglandins or ergometrines. An ADH-like response is given in high doses because it is close to pituitary. Should be given in electrolyte. Yes, very important clinical point. So this itself is a somewhat sodium depleting, something like that, electrolyte depleting oxytocin itself. So if you want to add in an electrolyte depleted 5% dextrose in water and give it as an infusion, it is not that good. So if you want to use it with infusions containing electrolytes, preferably ringer lactate. That is very important because already this, if you give, electrolytes will be less and there will be a water retention with oxytocin. So all these things may be there. So we may be relatively vigilant in giving oxytocin in ringer lactate. Serum electrolyte concentrations. There is a lot of doubt about whether the pregnancy and the labor progresses less in epidural analgesia. Is it because of the deficiency of oxytocin? Whether we cut down the epidural, cut down the pain with an epidural, we cut down the afferents. It is not with pethidine, morphine, or inhalational agents. If we cut down the afferents to decrease pain, yes, they have proved that there is some deficiency in oxytocin secretion, but that is not going to affect because we have extraneous oxytocin. We have a lot of instrumental deliveries. We know how to deliver with the instrumental. We have got how to deliver in patients with this thing. So many other things are now available. So this is not much of a problem. That doesn't. I'm not telling that the instrumental deliveries are more common with epidurals. Don't think like that. Now we go to carbetocin. This is another drug. Now we have finished oxytocin. Now we will go to carbetocin. It's an analog of oxytocin. It's a synthetic. Oxytocin is naturally secreting from above. Myometrial receptors has the same affinity, but it is longer half-life, 40 minutes. Heat stable, this is very important. Ergometrine, your methergine degrades. Misoprostol degrades, but carbetocin is heat stable. 100 micrograms can be action up to 120 minutes, or even you can give slow IV over a period of 1 to 2 minutes, carbetocin slow IV. If it is not needed to give in 100 ml NS, clear evidence tells that we can give carbetocin slowly over a period of 1 minute, 100 mics straight IV. There is no doubt about it. We can also use intramuscular. Again, the same thing, water intoxication, hyponatremia, nausea, chills, back pain, flushing, all these things are possible. That is why I told previously, carbetocin or oxytocin should not be with dextrose alone solutions. Now we will go to the next range of drugs, ergot alkaloids. Claviceps purpurea was the effective uterotonic drug. Pulvis add partum, the powder of birth. To pulvis add martum, it became like, because titanic uterine contractions. If you give methergine before delivery, uterine contractions, fetal asphyxia, death, uterine rupture, stillbirth, so many things happen. That is why they said it is a powder of death. They started using that as powder of birth, and it became pulvis ad martem, the powder of death. That is the problem with all these ergot alkaloids if we use as an uterotonic drug before the delivery. The RCOG guideline recommends an intravenous injection of 0.5 milligram for the management of uterine atony, 0.2 milligrams intravenously or intramuscularly. Prophylactic oral methergine or ergometrine has got no role. It's a second line drug. That is what is important. First line, prophylaxis or treatment, oxytocin. So all these things are second line and third line drugs. So 0.5 milligrams slow IV can be given, or people have used IM, but what I use is I always use subcutaneously because I feel subcutaneous action is relatively faster than IM, and it does not produce much of intravenous associated BP rise. This is what I feel. I always prefer in these 30 years to give subcutaneous, but this is not evidence based. Where it acts, ergometrine is a partial agonist of adrenergic, serotonergic, and dopamine receptors. It is not established well, and it may act for 120 minutes, the half-life itself, and it may act for 2 hours or 2.5 hours. Hypertony, uterine rupture, BP rise. This is very important. Coronary spasm, CVA, retinal detachment. So far, 8 cases. There is a lot of incidents of vomiting. After oxygen, maybe up to 45% see with ergometrine. So what all we have seen is severe hypertonic, vasoconstrictions, BP rise, vomiting. This is what most commonly I have seen because I never use IV. I always use subcutaneous. Coronary and renal artery spasm, many times clinically it may come and go. We have not seen much, but yes, they have been established and they have been found out with methyl ergometrine use. Ergometrine is contraindicated in eclampsia, history of hypertension, peripheral vascular disease, a patient with stroke, patient with hypertension, patient with all these things. It is also contraindicated if there is a suspicion of retained placenta. See, that is what is important. If at all, if you want to use for a retained placenta case, use it after the expulsion. Very important. People slightly placenta is inside. They are having retained placenta. I will talk of anesthetic management of retained placenta in a separate video. But here we should use methyl ergometrine only after the expulsion of placenta. Syntometrine is a combination of oxytocin with methyl. So sorry, ergometrine. 0.5 milligrams and 5 units. Yes, we can use intramuscular. The time is short, fast acting, 5 minutes or 10 minutes it may act, and the duration of it may prolong to 2.5 hours to 3 hours instead of 45 minutes alone with oxytocin. So that is the 15-20 minutes it may act very well, and 40 minutes it may act very okay for oxytocin. But this ergometrine may act for 2.5 hours. So this is the advantage of first isolated in seminal fluid, hence the name prostaglandins. They may increase intramyometrial calcium concentrations and enhance uterine contractions. Their effects are mediated by G proteins and activation of calcium channels. I've already told. Calcium the center. This is through this receptor and that is through that receptor. There the G proteins are mediated and the calcium channels are activated. Other roles of prostaglandins, gastric ulcers, inflammations, and patent ductus arteriosus. Is first isolated in seminal fluid that is called a prostaglandins. Cyclopentanone nucleus, and where is the substitution? It depends upon. It is actually from arachidonic acid. Carboprost is PGF2 alpha. These are two drugs which we should know. One is carboprost, another is misoprostol. Carboprost, it can be used IM or sometimes rarely intramyometrial. They have found a lot of problems with intramyometrial, so they prefer IM, and the second is intramyometrial. 125 mics or 250 mics. Rarely we can use up to 500 mics. We can repeat if you want, and 3-4 doses, and it should not be used intravenous. Severe hypertension, sometimes patient may throw fits. I have seen cases carboprost IV, patient throwing fits with hypertension. So then we used labetalol, epsoline, and Maxalf came down on that. So it was an accidental injection. So that was around long back, 15 years back. So carboprost should never be given intravenous. Stick to that. Even if you give IM, here you aspirate, there is no blood. It is not even going to some capillary. It is not even going to a small venule. Beware of that. And then give push your IM. So IM intrametrial 125 250. What I use is, if the patient for prophylaxis I use 125. For use I give 250. For bleeding I use 250, which I repeat after some time, another 250. For prophylaxis, yes, the uterus is little soft, but there is no bleeding. Yes, we can give prostaglandin. There is no bleeding at all. So then we can give only 125. That is enough. This is what is my practice like. This is about F2 alpha. Now I am going to misoprostol. This is E1. It's a cheap, widely available replacement. It's less effective than. See, think 200 microgram tablet sublingual rectal. It's a methyl ester. The first metabolism is high. So that is why we cannot give oral much. You should think of the dose. In preeclampsia, it's the second line, not the first line, only after oxytocin. We all know side effects of prostaglandins. Hypertension, nausea, vomiting, diarrhea, shivering, fever, glaucoma, bronchospasm, BP rise. Definitely you can get, in a patient with wheezing, if you get prostaglandin IM, the wheezing will increase and you have saturation slightly down, especially if you give GA. Especially if you give GA and if you give prostaglandin, definitely there will be airway pressure increase. So this we may not find out when you give routine spinal. When you may not find out, if you give GA a note after prostaglandin, within 10 minutes, you will see a rise in airway pressure. Nausea, vomiting, diarrhea, very important complications. This diarrhea will poison the field, and this nausea, vomiting, this side it is irritating to the patient. So I prefer to use ondansetron IV and then prostaglandin IM. More in PGE1, nausea, vomiting, and diarrhea. Summary: what are the stimulants? Why do we need that? To induce labor, to prevent or the prophylaxis of PPH, the prophylaxis, whatever it is, treatment or prophylaxis. The first initial, most important treatment is oxytocin IV. Give 5 units IV followed by 40 units in a solution. If that is not working, then you add prostaglandin IM. Yes, that depends upon you are using 250, 500 or only 125. Or we can use methyl ergometrine only if the receptors are there after 20-28 weeks. Ergotamines, all these oxytocin causes hypotension, while ergometrins and prostaglandin cause hypertension. This ergometrine can cause severe hypertension, which may progress for around 8 hours. We can see here. If you give ergometrine, sometimes the BP may be raised for around 7 or 8 hours. Prostaglandins, nausea, vomiting, diarrhea, gut stimulant, very important. Rather than this, yes, we should know the need. What is the scenario? Yes, it is not a retained placenta. Beware, you should not use methyl ergometrine. What is the route we are giving? IV, IM, subcutaneous, rectal, oral, sublingual. All these things are there. Some people use oral misoprostol immediately after delivery in spinal anesthesia. It's very common. So, or sublingual misoprostol immediately after delivery. So all these things are available, which we have to choose and which we have to think and give has to be decided by us. There are guidelines. Use oxytocin is the first thing, and PPH guidelines of prophylaxis, PPH guidelines of treatment are there. They are more towards obstetrics. Now we want to know about the drugs, when to use what. This is what is needed. Thank you very much for the patient listening. And again, subscribe to Painfree Partha YouTube channel. Thank you. Thank you very much.